What you find with myeloma patients when they've been gone through a number of treatments is that they already have early cataract formation. So cataracts form in elderly people anyway. But what we do find is that patients who've been exposed to oral dexamethasone, which we use liberally from newly diagnosed right through to relapse at high doses, have premature or early cataract formation. So typically if you have a relapse refractory patient in front of you, they will already have some visual disturbance, namely as a consequence of early cataract formation. So that has to be taken into consideration when you counsel the patient. Now, the toxicity associated with belamaf is not cataracts, it's at the front of the eye, which is cornea, which is something different. But nevertheless, if your overall visual acuity is poor, then you will need to counsel your patient that may deteriorate further. The other aspect to touch on is that the use of topical dexamethasone eye drops will also accelerate cataract formation. So you would need to counsel your patient that the likelihood is that they may well develop cataracts after being treated with belamaf, which you can then surgically extract. And that's fairly straightforward to do, as long as your patient is fit enough to have that procedure. So what I do find with patients, particularly in the relapse setting, is that they are very keen to receive this treatment because it's extremely effective. And when you talk to them about the eye events, then they don't seem to mind because they are receiving a very potent drug. And just to speak to that a little bit more, I presented at EHA the patient-reported outcome data from DREAM-1. And whilst patients were reporting that the most common aspect that interfered with their life was the blurring of vision and their potential inability to drive, they actually had a very high level of satisfaction at the end. And that was really because of the excellent myeloma control that they achieved. So really the question now that comes to the forefront is that given that we have a potentially very effective agent that works in relapse refractory myeloma, how will patients feel about the eye toxicity when they're newly diagnosed? I don't know how that will come across, and I think what we need to do in the meantime is to really understand why the eye toxicity happens and to fully understand how to manage it. Because once that happens, and that will happen as we get more experience with this drug, then we'll be able to treat the newly diagnosed patients more confidently.